Hello, I'm Viet Le, an Associate Professor of Research at Intermountain Health and a Preventive Cardiology PA. Thank you for watching this video series on cardiovascular kidney metabolic health. We've covered a lot: screening, staging, treatment, and now in this final video, I want to bring it all together and talk about how we can implement this in practice. There's a 4-step framework for managing CKM, and we've touched on each part throughout the series. First, screening for CKM risk, using tools like the AHA's Essential 8 and including our lipid profiles, blood work, but adding UACR and also BMI. Number 2, assessing cardiovascular risk, where we calculate ASCVD risk using calculators such as the Prevent and personalizing the conversation with your patient. Third, determine that CKM stage, and we've talked about stage 0 through stage 4. Lastly, reducing CKM risk, treating appropriately, promoting overall health, and continue screening, addressing social determinants of health as you discover them. At the heart of all of this is early detection, because these conditions compound over time, which increases the risk of ASCVD and even mortality. Treating CKM can feel complex, but here's how I like to simplify it. First principles: whether it's cardiovascular, kidney, or metabolic disease, the patient is at risk of a cardiovascular event, and lifestyle modification improves quality of life and it reduces risk across the board. Use therapies that go beyond surrogate markers. Don't just target lowering A1C or triglycerides, but actually those therapies that reduce major cardiovascular events. And that includes the following therapies: SGLT inhibitors, non-steroidal MRAs, icosapent ethyl, statins, and GLP-1 receptor agonists. Also, I would include ACE, ARBs, and ARNIs. Many of these medications treat multiple CKM-related conditions. For example, GLP-1s have been known to treat obesity and diabetes, as well as sleep apnea, and also reduce cardiovascular disease and CKD risk. SGLT inhibitors and NSMRAs are effective for CKD in type 2 diabetes, and also within heart failure, with or without diabetes. And for those patients, we should be implementing full guideline-directed medical therapies, which will then include beta blockers, ACE, ARBs, and ARNIs, as well as these SGLT inhibitors and MRAs. In a 2023 analysis looking at 13 trials, it showed that combination therapy in just 3 years can reduce the absolute risk of heart failure by 3.4%, 4.4% reduction for CKD progression. For cardiovascular death, reducing that risk 2.4%, and finally, reducing by 3.1% all-cause mortality. So, how do we make this work in real life? Well, you start with frequent follow-ups as you initiate therapies and begin titration, extending those intervals over time as you and the patient both become comfortable that therapeutic targets have been met. Lastly, and most important, engaging in shared decision-making with the patient, helping them to understand and make that decision with you as a partner. How does shared decision-making improve this, or what does it improve? Well, it improves patient knowledge for sure, and their satisfaction in the care that they're receiving. Also, in adhering to the therapies that both you as a clinician and the patient have decided upon. How do we do this? How does shared decision-making happen? Well, number one, we foster a conversation. And that means defining the problem together, the pathophysiology, the prognosis, the therapies, and potential side effects for long-term chronic management. Then we adopt that process to match it with the patient's values, their goals, their needs, and of course their preferences. Number 3, we want to support that process. So we use tools like decision aids, infographics at the time that we're caring and as we move along with text messaging and education as chronic management goes further. Lastly, evaluating and learning. We have to go beyond the outcomes and be comfortable seeing what works as therapies Dosing titration can become highly variable for each patient as we meet them in clinic. Yes, it's challenging. We face so many barriers to being able to do shared decision making appropriately, like limited time in our clinic visits or even on our clinic schedules to get patients to come back in for follow-ups. We're against this need to act quickly, titrating as soon as we can and adding therapies early on, as that is where we see risk reduction. And of course, low health literacy. Each region and each patient, culturally, etc., these are the social determinants of health that may impact the ability to converse about disease and the therapies, as there's a lot of complexity that occurs with CKM. Well, we can overcome these barriers if we're intentional about communication, about patient education, and of course, allowing for team-based care. It takes more than one clinician to be able to provide optimal care for these patients. We've covered a lot in these short videos, but here's the main takeaway. PAs are not only capable, we are empowered to make meaningful treatment decisions with our patients that reduce cardiovascular risk and improve care. Thank you for watching, and I thank you for all that you do and all the work that goes into care every day.